Thank you, So the first case is a very vague title, and you'll see why it's titled that way. Echo in the assessment of MR, of management, assessment and management of MR. So this is a 46-year-old man who had a late presentation of an anterior wall ST elevation myocardial infarction in June of last summer. He had a bare metal stent delivered into the LAD, which the stent abutted the diagonal but did not occlude it, did not jail it, if you will. He also had significant coronary disease in the diagonal itself and the ramus. The next day he had recurrent chest pain, severe chest pain with ST elevation. He underwent an urgent recath and he had an acute stent thrombosis in the LAD stent, bare metal stent. He underwent a POBA, plain old balloon angioplasty inside the stent, and was put on a 2B3 inhibitor, and his medications otherwise were obviously continued, the dual antiplatelet, oral antiplatelets, thienopyridines, and that was that for the ischemia, but he did have problems with recurrent heart failure. Based on the angiogram, this guy had a consultation by the cardiac surgeon. There was a discussion, they felt, given he was young and given that he had disease in other territories that were quite significant arteries given their distribution. He was referred for coronary bypass surgery, which he had done. So he had a left internal mammary artery edema to the LAD, a saphenous venous graft to the first diagonal, and a venous graft to the ramus. Post-operatively, he suffered from recurrent heart failure and atrial fibrillation. His echo showed severe LV dysfunction, EF 23%. He had an LV apical clot and severe mitral regurgitation. He had an ICD inserted prophylactically, and obviously was anticoagulated for his clot, and etc. So the medications he was on were aspirin, spironolactone, warfarin. Now this was 6 months later. Ramipril, 10 milligrams a day. Furosemide 120 BID, atorvastatin 40, metoprolol 25 in the morning, 12.5 in the night. That was as high as we could get it given his blood pressure, and amiodarone 200. So on examination, when we saw him, this was about, probably 5 months after his infarct and bypass. His blood pressure was 87 over 63 millimeters of mercury. His heart rate was 99. His JVP was 12 centimeters above the angle of Louis. He had an S3 and a 3 out of 6 pansystolic murmur at the apex radiating to his back. His chest was fairly clear, and he had 2+ bilateral pitting edema. And he was an outpatient at this point. Now, he was very ill. He couldn't lie flat. Since his heart attack and bypass surgery, he was unable to lie flat. He slept in a chair, and he was a young guy. His life was intolerable, he said. So this was his echocardiogram when he was on optimal medical therapy, when we saw him 5 months later. So, any comments? Anybody?
Dilated ventricle, severe impairment, severe mitral regurgitation, dilated right side. I think heart function is also impaired.
Yeah, good. And significant TR, maybe moderate TR. Excellent. What I'd like you guys to do whenever you assess regurgitation of any valve, I always tell my fellows you must state the mechanism. So in my view, in our lab, it's insufficient to say in isolation there is moderate aortic insufficiency. You have to say this is likely due to isolated aortic root dilatation with normal aortic valve leaflets, because this has major implications for intervention. I don't know, are there any cardiac surgeons here? No. So, but it does have major implications for, and likewise with the mitral valve. So, having said that, somebody want to help us understand what is the mechanism of the MR likely?
There is a restriction in the mitral valve, but if you remove the color too much.
Yeah, I can't remove the color right now.
But the jet is central, so.
Cardiomyopathy, functional.
Yeah, it's functional MR. So when you think of MR, mitral, it's either primary organic. So these are words people use interchangeably. Primary organic, which is, myxomatous valve disease, endocarditis, valvulitis, valvulopathy of any primary type, or secondary. And secondary to the supporting structure of any valve. In this case, it's a left ventricle. So this would be really from apical lateral differential displacement of the posterior medial anterolateral pap muscles, resulting in apical tenting of the mitral valve apparatus, which is usually asymmetrical. It's usually the asymmetry of the tenting that results in the functional MR. So it's functional MR, it's very important. So always one must think of those things. So here's his peak TR velocity, okay? And his JVP was 12, add 5, 17, about 13, 14 you can add to this. So he had a pulmonary artery systolic pressure of 55 to 60. So his moderate pulmonary hypertension. Okay. Those are his findings. I think they're well summarized by Dr. Sharif. Okay. And what are this guy's options? Continued medical management. Who votes for that? So continued medical management really means palliation in these type of patients, right? It's palliative. I mean, the guy's young, he sleeps in a chair. So now if you're 95 and you sleep in a chair, it's one thing. But if he's 40-something sleeping in a chair, it's unacceptable, right? So in my view, it's palliation. LVAD, who thinks he should be referred for LVAD, bridge to transplant type of assessment? Anybody?
Some form of study as well, or can I just send for LVAD without further assessment?
Yeah, well, let me rephrase a good point. Our center doesn't do transplant. So what I would say in that case, I pick up the phone and call Heather and say, Heather, this situation, she says, don't call me until you filled out our lovely University of Toronto heart failure transplant referral form, which you need a PhD to fill out. Just kidding. There's a form you have to fill out. It includes cath and all that stuff. So it's all that stuff. So who would start the pathway of potential LVAD transplant assessment? Okay. Who would refer for surgery? Okay. Who would refer for percutaneous mitral valve repair? Okay. And who would, well, transplantation LVAD, it's sort of, one and the same as we discussed. So he was advanced actually for percutaneous mitral valve repair, MitraClip. Let's talk about that. So I'll show you what we did, and then I'll talk a little bit about MitraClip, which is, it's a brand name made by Abbott Vascular, and I'm not here to promote any company at all, but it happens to be, to my knowledge, please correct me if I'm wrong, Heather, the only commercially available percutaneous mitral valve solution in Canada. Yep. Okay, so that is what it is. So let's talk about this. So this is a transesophageal echocardiogram. This is done we do this in the cath lab, in the cath lab suite. So because the esophagus is posterior to the heart, the most posterior structure of the heart is so always the first structure directly from the probe is at this apex of the ultrasound, is the left atrium. Always, always, always. So you always start with that. Left atrium, anterior mitral leaflet, posterior mitral leaflet, LV. What do you see here? Thank you. Is ICD in the right ventricle? Very good. Right atrium, intraatrial septum. Okay? Good. What do you see here? We always, and this is I time and time again remind people, we always display the systolic blood pressures as measured 4, 5, 6 times during the sedated TE on the screen. So when someone comes and reviews it, so Heather reviews my TE, she knows how to interpret the MR, because I will show you MR is so exquisitely load dependent. And if I had $1 for every time I was called to the operating room because someone was sent for mitral valve repair and the MR was all of a sudden better, and the guy's filling pressure was low and his systolic pressure was 70, I'd be a millionaire. You have to make sure the patient's full and tight. Okay, so tight meaning there's a little bit of afterload squeeze. Having said that, 90/50 is what this guy lives at. And in respect of transesophageal echo, if someone's referred from the transthoracic echo for severe MR when his outpatient blood pressure is 140/90, then we keep him NPO for 12 hours and sedate him and his pressure is 90/50. The MR can be very different. It's a very critical point. Okay, so there's a lot of MR here. Now I always say it's not about what's in the atrium, it's about what happens at the valve level, because it's the effective regurgitant orifice area is really the size of the hole we're interested in, and the proximal isovelocity surface area pisa and the vena contracta more closely relate to the size of the hole than do entrainment and other artifactual phenomena of the Doppler signal in the left atrium. So always concentrate at the valve coaptation point. So as Dr. Sharif said, it's a central regurgitant jet and severe mitral regurgitation. Okay. All right, another view here. Okay, and you can see the aortic valve is fine. So this is our three-dimensional echo, and I'll show you why it's very important for MitraClip. So basically, the marker here is always the aortic valve, and I can't manipulate this because it's just a JPEG. But this is the anterior mitral leaflet, which is also adjacent to the, always adjacent to the aortic valve. This is the aortomitral curtain, if you will, or the intravalvular fibrosa, though this is a bit more in the atrial aspect. And we're looking from the, that's what the arrow is, LA to LV. So we're looking atrioventricularly. Here's first anterior scallop, second or A2, third P1, P2, P3. So this is not the best rendition, but this can be very helpful for regurgitation, especially when there's paravalvular leaking, when we have a prosthetic valve, so three-dimensional color transesophageal echo. Okay, so what are we doing here? Excellent. So this is called tenting. So we have, you do this procedure by gaining access in the right femoral vein, advancing the wire obviously into the right atrium, and then you're gonna puncture across the interatrial septum with a Brockenbrough needle, and this is your puncture here, and you can see the wire is across the left atrium there. So this is our little iatrogenic ASD that we've created. That's a little bit of TR there. So we're across. Okay, and you can see now that our sheath is in the left atrium. So this is the aortic valve. This is the right atrium. This is the right ventricle. This is the left atrium, is always at the top of the image, posterior to the heart. And you can see here, adjacent to the appendage, is some of the catheter here. And there are bubbles in the left side of the heart because we've gone across. And whenever you're flushing, no matter how watertight the system is, there's always some bubble, okay? And we spend a lot of time flushing the system. So this is why the three-dimensional echo is so phenomenal in this scenario. So you can see where this is the interatrial septum here. This is the guiding catheter. This is the MitraClip. It's like a little cross. I'll show you pictures of it. And we're advancing it atrioventricularly across the mitral valve. What's this little structure in here? Aortic valve, yeah. Okay. So this is a little MitraClip here. Again, because then we position it, what we try to do is we have to grab both leaflets. And it takes a lot of skill. I don't do it. Shamir Mehta does it. Dr. Mehta is a very well-known and talented interventionalist. But it is completely echo-guided. So as opposed to transaortic valve replacement, TAVR or TAVI, which you can actually do without echo, in my view, because you have calcium that demarcates the annulus where you insert the percutaneous valve. MitraClip is completely T-dependent, so we completely guide the interventionalist. Completely. You cannot grab leaflets which have no calcium on fluoroscopy. It's impossible. Right? Makes sense, right? Impossible. So it's the only thing that's completely dependent. The Watchman, which we also do, the left atrial occluder device, is mostly T dependent, but you can, in the most skilled hands, do it without T. But this is by far and away the most T dependent interventional echo we do. So here's the mitral clip grabbing the leaflets. Okay, again, we're across, you can see how we're across the septum. Now this is very interesting. So we're able to just, with a button, three-dimensional echo, flip the image. Now look where the arrow is. We're looking ventriculo-atrially. And what have we created here? By grabbing the leaflets. What have we created? Very good. A bi-orifice mitral valve, akin to what surgical intervention? Alfieri procedure. So this is in effect a percutaneous Alfieri. Alfieri from the Italian surgeon who for functional MR did a stitch between A2 and P2 of the mitral valve and created a bi-orifice mitral valve to prevent regurgitation. So we've created a percutaneous Alfieri. Everyone's okay with that, right? You see the two holes there? 1, 2. Okay? Now, this is the result after one clip. How much MR is there?
What's the blood pressure?
Yeah, that's a good question. The blood pressure was about 88/50.
It's less.
It was mild to moderate. Now, this is only one view, but other views it was mild to moderate. So who would stop there? Remember, we're not trying to, perfect things. This is also a palliative procedure, right? We want to reduce the regurgitant volume that the LV has to encounter with every diastolic filling period. So who would stop there? Who would do something else?
I would stop.
You would stop?
Yeah.
Sorry?
Is there an indication to occlude left as patient has fibrillation,
Yeah.
anticoagulation?
Yeah, we could do that. We can. That's a thought. But his main problem is heart failure. So we'll tend to that first, and then later date we can consider the other options.
Keep going.
With what?
Another clip.
Yeah. So we debated this, and we thought we'd probably put another clip because it's mild to moderate MR. So what we did was put the sheath back, across the septum. This is actually two clips side by side. Let me show you better. So this is the original clip here. Can you see it? It's deployed. This is the second clip being delivered on the delivery catheter. So clip 1 already there, clip 2. And this is the delivery of the second clip. How much MR is there? Trace. Okay. How much? So there's two clips. You see them? 1, 2. 1, 2. Trace MR.
So the first clip you put it on A2 and P2.
Yeah.
Yes. So where did you put the second clip? A3 and P3?
No, it was actually the junction of A2, P2, A2, at the junction of A2, A3, and P2, P3.
Oh, so you closed totally A2 and 3, B2 and 3 are
No, it was at the junction. So effectively, they were confined mainly to A2, P2.
Okay.
Yeah, that's a good question.
Yeah.
Okay, so there's the MR there. And I can tell you, listen, when we started this program and, MitraClip, and MitraClip is not easy. This is not TAVI. This is, the interventionist worked a long time perfecting the manipulation of the gear. You've seen it, right, Alwad?
I'm not really.
It's very, but once you get it, but it took a lot of work. It's not a joke, okay?
Now we do TAVI here.
You do TAVI here. But the MitraClip, with all due respect to everyone, is a different level of skill. It's very demanding. But so we had a lot of reservations about doing this program, but I'll tell you, the cases we've done so far, it's unbelievable. If you select properly. This guy immediately could lie flat. It was the first time since his heart attack he could lie flat. His JVP went down from 12 to 4 the next day, the same, like right after. His PAP went down by 20, and that was one day. We didn't even assess it long term. And he said he felt great. Now you can see this placebo effect, but I'm telling you, the MR, if you think about hemodynamically, that regurgitant volume was essentially gone. Right? And it's not like putting a mechanical valve in where you create distortion in the mitral valve apparatus and a mechanical afterload challenge. This is a very different intervention. So this is his transthoracic echo like 2 days after the procedure. So you see the clip there, folks? LV, LA. What do you think the RV function? It's still down, but it's better. It's not as dilated. There's a little bit of P's on the inflow, so you always have to assess for. What do you always have to assess for after mitral stenosis with anything? Okay. So here's his CW, mitral CW, continuous wave Doppler, gradients of 3 and 4 at a heart rate of 76. So really no mitral stenosis. Here's his TR jet, went down to 33 to 37. So these are his images. This is pre, so this is the 9th of October 2014. This is post, when we, after his TAVI, 12th of December 2014. See the difference?
Amazingly, the left ventricle also looks.
Left ventricle's a bit better. Look at the right side though.
Yeah, the right side.
The right side is smaller and it's working better. Okay?
TR also is almost gone.
TR is trivial, right? Because essentially what we've done is we lowered his, because we could transduce, his LA pressure immediately went from mid-30s to low 20s, immediately. Because you're there, you just transduce the catheter. There's no big mystery there. So this is his TR before. And what are the differences in the TR here? What about it? Okay, the slope is different. The velocity, and the what would you say? Yes, the density of the jet is less. So it's clearly less TR. All that, okay? So this is the mitral clip, basically. It's a clip that's housed in this material, and these are the graspers here. And so it's 5 millimeters broad when closed, 15 millimeters in length, 9 from the closure point to the end of it, and when fully open, 2 centimeters. So what you do basically is, we do this in the cath lab. We're building a hybrid lab, but we can do it in the cath lab. So under general anesthesia, because mainly you can do it awake, but it's really the comfort of having a transesophageal probe in there for several hours, okay? And then basically it's a big one. It's a 24 French, and we do a per close after. And the femoral vein obviously has a Foley catheter. Full heparinization because of risk of stroke here in the left atrium after all. The activated clotting time over 250. Okay, and we spend a lot of time de-airing the thing you don't want a big air bubble going directly to the brain. And basically that's it. That's how it works. It takes a lot of skill though from the operator, and there's a lot of coordination with the echo person. So here it is, transeptal, RA, LA, delivered down. Here's a corresponding image. This is a closed clip. Anterior, posterior mitral leaflet. You always know the anterior is beside the aortic valve here. Okay, now here's the, we're trying to grasp between the grasper and the clip, the posterior and the anterior leaflet. That's what it looks like. So you're creating a surgical Alfieri bi-leaflet valve. I showed you a very similar image here. And then once you're happy, you release, and that's pre and post. What are the recommendations? So very interestingly, it is approved conditionally, actually some maybe not approved, let me restate that. It is recommended on a 2B, so consensus recommendation, relatively weak evidence or moderate evidence for use in primary degenerative MR, meaning myxomatous valve disease in someone who's not operated. Because that was where the first study, the Everest study, most of the patients came from. We're now doing the COAPT study for functional MR. However, most of the patients we consider are functional MR because our surgeons are so good. If someone has a myxomatous flail valve, you have to have a major surgical contraindication, major, to not get it valve repair, open valve repair, or mini mitral procedure, surgical mini mitral. So really where we find it particularly useful is in functional MR. And in the select cases we've done, I've seen unbelievable short-term results, short-term. I cannot comment on long-term, but what I've seen in functional MR is excellent short-term results, 6 to 12 months. What happens in the long-term, God only knows. But this also does not obviate or exclude this patient from other options. So let's say we buy him 3 years. What's wrong with that? You know, he's 48. Then I can pick up the phone and say, Heather, we have a problem now. Can you take him over? And she'll take him, and they'll do all the cath and all the hemodynamic assessment. Hopefully, he'll end up on with a new organ. But this is what we're doing here. So conclusion: percutaneous mitral valve is a viable and effective option for patients with selected patients with primary organic MR. We're not doing those really. We're doing functional MRs. That's where we find it attractive. These patients must be turned. We have a team, so the surgeon has to turn down the patient, and our surgeons are very aggressive, extremely. So the patient has to be turned down. Now, this guy you would not send to the operating room. I would not. Would you send this guy to the operating room? No. There's no way I would send a guy like this for open, even mini mitral. This is why you end up with the mitral clip. And echo is an incredibly important guiding procedure for this intervention. So, having said that, any questions in the audience?
Sorry, I maybe missed this patient had a coronary angiography.
Sorry, he had, yeah, you remember he came in with an anterior wall myocardial infarction. Yeah, well, he had an anterior wall myocardial infarction, so we have a 24/7 STEMI program. And he had a bare metal stent delivered to the left anterior descending artery. He had disease, if you may recall, in the D1 and the ramus, and so he was advanced for bypass surgery. He's an ischemic cardiomyopathy. Any other questions?
So just to have a comment about the mitral valve clip. I think the question always is about the long-term results, because actually about 50% of them will have again severe MR at 6 months, and probably about 80% at 1 year.
How do you know that?
This is from the study.
That's not my recollection.
The results are not that good.
Yeah, right.
That's why it's not approved, as you see there.
Which study are you referring to?
I think Everest.
Yeah.
First trial that was there.
You know,
Done on mitral valve.
yeah, maybe, but my reading, I don't remember those kind of data. So the results were excellent, and they were non-inferior to surgery. So, yes, sir.
By the guidelines, the association guidelines, you treat functional or ischemic MR. The patient for full medical therapy and still he has severe MR. Is class 2B indication to send him for surgical repair?
Yeah. So would you send this guy for surgical repair?
No, with the guidelines. It is
Yeah.
class 2B indication to send him for surgical repair.
Mm-hmm.
Is there a recommendation to send him for once continuous mitral valve?
Yeah, I didn't write the guidelines. I don't know them that well, but I don't recall them recommending a guy with severe MR and a EF of 23% functional that it's recommended for surgical repair. Do you recall, Heather? I don't recall that being in the guidelines at all. Yeah, no, I understand which guidelines they are, but I don't think that's in there. Yeah, because I can tell you, no surgeon in my hospital or Toronto likely would touch this guy, because what are you going to do for him? These guys don't get off pump very easily. So in my view, I'd like to hear Heather's thing. If you don't have an LVAD program, you wouldn't even think of the surgical repair, because you may not get him off pump. Heather, what do you think?
Yeah, I mean, I think if you were seeing this patient before his initial bypass surgery, obviously, and you found that degree of MR in your intraoperative echo, our guys would fix it at the same time that they were doing his original bypass surgery. I think that is certain. I think that once the bypass surgery has been done and now you have a guy with severe functional MR, I think you're in deep trouble. And you know, for functional MR, I think that the data in heart failure is still, unfortunately, not really great for surgical intervention. It would be a second-time redo. And if you can't get off pump, then you're looking at putting a VAD in somebody that you've put a mitral valve in, and you will have had to have made your decision about putting a tissue valve in or repairing it, because if you put a mechanical valve in, then you want to VAD the patient. That's a whole different set of challenges, and we'd have to actually deal with the valve because we don't like mechanical valves in the setting of VAD. So I mean, I think the whole reason the growth of mitral clip has happened is because after the original reports on surgical intervention for the mitral valve in functional MR and heart failure were suggestive, the post hoc analysis and really looking at patients and matching them showed that in fact there wasn't really a significant benefit for surgical intervention in functional MR in heart failure. So when you're in there the first time, yeah, if it's there, you fix it. I think everybody would do that, our guys would do that. But after the bypass surgery is done and now his LV is still dilated and he's still got severe MR, no, we would not want to go back in. We would actually send the patient for mitral clip. That's sort of been the routine that we've done, ensuring that I'm vasodilated and done all the appropriate medical things, because maybe I can get his MR better if I actually truly aggressively treat him. So that's obviously going to have been done. And if they still have severe functional MR,
that's your option.
We would not opt.
That's actually the only thing I would add to this is this. In my experience, when they address the mitral valve at time of surgery, I am not convinced that what they do to the valve is really what the issue is. What's the problem with why is there MR? The ventricle. If the ventricle does not respond to revascularization, that is the factor that's going to determine if there's MR after that. I don't know if you agree with that, Heather. So what I've seen is they put in a ring, they may do a quadrangular resection. I don't think if the ventricle stays severely depressed and dilated and continues to dilate, I don't see in my practice that the mitral valve intervention is durable. Because it's really a ventricular, that's why I talk about mechanism. If the mechanism is the ventricle and the ventricle doesn't get better, then just putting lipstick on the pig, if you will, so putting a mitral annuloplasty and quadrangular resection, plus or minus, doesn't usually do the job. Maybe. Okay, let's go to the next case. So this is called the importance of flow. So this is a 89-year-old woman who complained of significant dyspnea, denied chest pain or syncope, history of hypertension only, was on aspirin 81 and hydrochlorothiazide 25. So a very common presentation for this age group. We see this all the time. On exam, heart rate was 55 and irregularly irregular. Blood pressure is 153/67. Respiratory rate 16. JVP was 6 centimeters above the angle of Louis. S1 was normal. S2 was soft. There was an S4. She had a 3 out of 6 late peaking systolic ejection murmur at the, I should say, right upper sternal border. The chest was clear and there was no peripheral edema. So an echo was performed. Okay. So this is the echocardiogram. Parasternal long axis view. This is actually pericardial fat, guys. It's not a effusion because you can see the speckling. This is the right ventricle. Here's the aortic valve here. Left ventricle, left atrium. Any comments from the audience? Okay, so try to synthesize that type of thing. That's like the NSA listening to cell phone calls, actually. But they have a supercomputer to filter. I don't. But basically, there is concentric LVH. There's no hypertrophic cardiomyopathy, because what causes obstruction hypertrophic cardiomyopathy is always, 99% of the time, systolic anterior motion of the mitral valve, of which there is 0. Okay? The aortic valve is calcified and restricted, and the left atrium is large due to what? Diastolic dysfunction because of hypertrophic LV with an added afterload challenge from aortic stenosis. So that's what we see here. Okay. What else do we see here? Yeah, there's some. So there's obviously flow acceleration across the aortic valve, trivial AI, and some MR. We need more images, but it's not trace. Yeah, aortic stenosis. So which view is this? Yeah, so the ASC would call this the RV inflow view. Okay, so this is the tricuspid valve. Here's a trick question for you. Which leaflet of the tricuspid valve is this? Posterior leaflet? Is it the posterior or the septal? Why is it not the septal? You can't see the LV, excuse me. If you don't see the LV, so if this is the septal tricuspid leaflet, if you see the LV there, septum, otherwise it's the only real transthoracic view where you see the posterior leaflet, the tricuspid valve, and this is the anterior leaflet.
And you also see the coronary sinus.
Yeah, the coronary sinus coming in. Okay. So what do you, some TR there, mild to moderate, okay, fantastic. Maybe moderate. So RVSP about 30 plus RA pressure. So this is the aortic valve. It's a tri-leaflet valve, and what can you say about it? Yeah, it's restricted motion. Obviously, we don't comment on degree, probably even presence of stenosis, or certainly degree without Doppler. Okay, but it's definitely restricted and calcified. Sorry? Oh, yeah, it's a tri-leaflet valve, exactly. So there's some mild aortic insufficiency there. What? LVH? Okay. Yeah, left atrium's big. Why is left atrium big? And? Patient has a history of AFib. So when she came in, she was an AFib. So there's basically, that's what it is. So what is the ejection fraction here, folks? Normal, mildly depressed, moderate, or severe? It's normal. That doesn't mean there's no systolic dysfunction. That means the ejection fraction, the percentage of blood ejected across the LVOT versus that received by the LV and diastole, is over 52%. That's all it means.
Given the fact that it's hypertrophied, you expect to see higher than this in the 55 to 60 or more. But so this.
Yeah, we're going to get to that. Yeah.
And 50, 52, so it will be a little bit depressed function.
Yeah. So this EF was calculated at 67%. It's clearly bang on normal. But I'll talk about the flow issues here. So what is this, folks? Well, first of all, what is it? Okay, so the young lady here on the right-hand side got the gold medal on that. It's continuous wave Doppler across the aortic valve. Okay, and what does it show? Well, forget moderate. What does it show? It's all here. So your peak gradient is 49. Your mean gradient is 27. And the other ones, we always trace 3 or 4 of them, you know, and then 51 and 31. Okay, fantastic. What's this? Pulse wave across the LVOT, and this is the most crucial piece of information in anyone with aortic valve disease. Why? It gives you dimensionless index, but because it gives you flow. In fact, this is the most ignored piece of information on echoes worldwide. Because if you position your sample volume within 1 to 1/2 centimeter of the aortic valve, so sometimes you see aortic valve closure only, and you get rid of your Doppler spectral broadening artifact by decreasing Doppler gains, and you do a nice trace of the envelope, you multiply that by the LVOT diameter divided by 2 squared times pi, and that gives you stroke volume. Excellent. The most important piece of information on every echo, as long as it's done well, so, and you can cross-reference it to your, what's the other way to get stroke volume? You get it from 2D. So you get your end diastolic volume from Simpson's method, your end systolic, the difference. So we always cross-tabulate them to make sure we're accurate. Okay, so stroke volume is 49.9. Stroke volume index is 31. What does that tell you?
It's low.
Right.
So this is the cause of low
Excellent. Low flow, good. Excellent. We're going to talk about that. That's what I want you to remember. What does this show? Okay, Doppler velocity index is simply the continuity equation without the LVOT dimension and area from the hemispheric equation. But essentially, less than 0.25, meaning there's a quadrupling of the time velocity index or velocity or more, is consistent with severe stenosis. 0.25 to 0.3 is moderate severe. 0.3 to 0.4 is moderate. 0.4 to 0.5 is mild. Greater than 0.5 is insignificant. Make sense? And the advantage is it gets away from the errors that are inherent in LVOT measurement. Okay. So how much aortic stenosis is there? Severe. Okay. Severe, okay. So the mean gradient is 29. Valve area is 0.6. DVI is 0.2. So if you consult the guidelines, they will say there are discordant or variables that don't agree with each other. So my question to you is, why is the AV mean gradient lower than expected for the aortic valve area? Double load. Okay.
And the aortic stenosis by itself. By stroke volume less than 35,
yeah.
The new guidelines, it is severe if the area is less than 1. So
okay. Let's keep going. I think a lot of those points are very good points, and we're going to incorporate them into a final analysis. So what's this? How much? Mild to moderate. Moderate. Always make sure your Nyquist limit is above 55 or 60. If I had $1 for every echo that was referred to our surgical center with severe MR, where the Nyquist limit was 40, or the Doppler gains were jacked up, and they actually don't have severe MR, I'd be a millionaire. Well, maybe not a millionaire, but I'd do pretty well. Technique and settings are important. Right, Dr. Sharif? Not setting them up, you are going to make errors in judgment. So mitral inflow, not to belabor this, but very high filling pressures, E wave of 1.5. So how much MR? People said moderate, that's fine. So let's break down the baseline variables. This patient has significant dyspnea in the setting of normal EF, severe aortic stenosis, moderate MR, high LA pressure, and normal PA systolic pressure. Okay. Now, it's well recognized that patients who have low ejection fraction, less than 40%, can have low stroke volume. And if you have low stroke volume, then you would get lower than expected mean gradients for a calculated valve area. However, we know that low EF is not the only cause. Anything that causes low stroke volume, like small hypertrophied left ventricles, like in this woman, her end diastolic volume was only 78 cc's. Okay, small body surface area can give you low, and that's called paradoxical low flow AS. But also RV dysfunction, she doesn't have that. Significant TR. If I have wide open TR, my LV stroke volume is low because the LV doesn't get the adequate preload from the right side. Significant MR or MS can decrease stroke volume, as can atrial fibrillation. So you have to think of these things when assessing aortic stenosis. Okay? So this patient was thought to have severe AS. LV gradient was due to a small hypertrophied ventricle and MR. That's why she had low flow, a lower than expected aortic valve gradient for the degree of aortic valve area. She had non-obstructed CAD on the cath. And she was advanced for trans-aortic valve replacement because she had elevated creatinine. She was kind of frail. You could do open surgery. I have no problem with that. But she was advanced for TAVR. Okay? So the TAVR went well. It's great. Cures everybody. And it cures everyone as long as they're over 100 years old. So basically, went well, no complications. That was a joke, by the way. Because our TAVR population is ancient. So there's old and there's TAVR old in our hospital. Okay, so I don't know if it's the same with you, Heather, but let me tell you. So post-TAVI, we had one patient, amazing, was hemiparetic with a stroke, had TAVI and his stroke didn't get better. I don't know why. But basically, the patient was significantly dyspneic after the TAVR. The heart rate was 68 and irregularly irregular. The blood pressure is 177/92. Much worse dyspnea than pre-TAVI. What's the problem? AIs, whoever said that, perfect. You always have to think of a valve disruption, but I've almost never seen that. If they get out of the HIU or the hybrid suite, the cath lab, with T showing a very good anchoring of the aortic valve, because these are calcified roots, so it sticks in there. Usually there's no late embolization, usually. But you have to think of it. AI, paravalvular AI, whatever. What else? Yeah, from what?
The microregurg, either from the TAVI itself, if it is malpositioned or something.
Yes? Hypertension. Good, 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 excellent. We did an echo. So this is the echo. LV function looks pretty good, right? Same as before. The TAVR, I mean, looks great, doesn't move. Again, great points, but if we anchor it well and we do a T before they leave and it's anchored well, doesn't budge, there's no ischemic AI, usually it doesn't go anywhere. But you always think of it, right? Okay. What do you see here? Okay. Some TR there. What's this? Do you remember the other TR gradient pre-op? Did we do it? Look. This was pre-TAVI. So the velocity is different. What else is different? Yeah. Look at this. That's not good, is it? Okay. So with that IVC add 10, you have a PA pressure of 75. Okay? So she had moderate to severe pulmonary hypertension because she has systemic arterial hypertension, so it's not greater than 2/3. Okay? LV function looks pretty good. What's that? Okay. Take a good look at that. Very good look. Hold that thought. Hold that thought. Hold that thought. Take a good look at it.
Well, what I see here is my paravalvular leak from it's paravalvular leak from the TAVI itself.
Agree 100%. Okay? What does this show? No, no, no. What is this? LVOT pulse wave. What is the piece of information I told you to derive from that? Okay, what's the stroke volume? What was it pre-TAVI? 49.9. So the stroke volume's gone up. Okay? Why has the stroke volume gone up? The mitral regurg is adding more preload. Good. Okay? This is the CW across the valve. Early peaking, nice. If it was obstructed, you have late peaking. Velocity is negligible. Mean gradient's negligible. So to make it quick, there's no prosthetic stenosis, and as the gentleman said, there's mild paravalvular AI. The data shows almost all AI after TAVI is paravalvular. If it's mild or less, it has virtually no prognostic importance. If it's greater than mild, it has a prognostic importance. That's all you need to know. Okay? What's this? Severe MR, right? Okay. Severe MR, right? Okay. So how much MR? It's severe. So usually post-TAVI, what happens to the MR? Right, because you decrease left ventricular afterload. So less back pressure in the mitral apparatus. Okay? In this case, as you guys said, this patient's had acute hypertension because what they do, they hold all the meds, right? Hold everything, and you know, basically the anesthetist pumping with fluid because trained after someone goes to any intervention to give them fluids, right? It's good for you. So all the meds were held, pumped with fluids, and developed severe MR. So the point of this story is that MR is incredibly volume and afterload related, so you must consider those hemodynamics. And this patient's stroke volume, like flow, is very important. This patient's stroke volume went up because there's this huge amount of MR that's coming back into the LV in the setting of good systolic function, so she went up on the Frank-Starling curve. Now, if this patient had a depressed ventricle with severe MR, the stroke volume may go down. But she was able to respond with the LV, so it went up. So anyway, the moral of this story is simple, that echo is not just this, you know, what's the EF, and then you leave the lab, 1,000 things that tell them they're running away, okay? It's a hemodynamic assessment, and you have to think of it as a non-invasive cath lab. In fact, in my view, and at Baylor College of Medicine certainly, and increasingly at MAC, interventionalists are saying, you know what, you guys do a full hemodynamic assessment. If there's controversy, we're happy to do a left and right heart cath. But for the usual stuff, mitral valve, aortic valve, filling pressures, echo's good enough. Would you agree with that, Heather? Yeah. So it's really echo, think of it please, if you will, the one message going home today. It's a full hemodynamic assessment and should be treated as such, as long as it's done well. Thank you very much.